Nikhil bhai.
So we can start.
Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Riya Balikar from Nagpur, and she's going to lecture us on transforming treatment paradigm in chronic lymphocytic leukemia. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Natco, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Roche, Unipath, Natco, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Dharmesh Vagasia from Surat. Our guest speaker for the day, Dr. Riya Balikar from Nagpur. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists. And you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 18th of October 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. US Central Time. We have Professor Dr. Anand Patel from University of Chicago, US, speaking to us on accelerated and blast phase myeloproliferative neoplasms. And the following day, that is Sunday, 19th of October 2025, from 11:30 a.m. Indian Standard Time and 7 a.m. London Time, we have Dr. Claire Harrison from London, UK, speaking to us on polycythemia vera treatment in 2025. Let me introduce our discussions for the day, and they're displayed over here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day, which are all eminent hematologists, hemato-oncologists across the country. So these are our discussions for the day. And now it's the time to introduce our guest speaker for the day. We have with us Dr. Riya Balikar from Nagpur. Dr. Riya Balikar needs no introduction. She is very well known in this part of the world, and she's MD, DM, and DNB hematology, consultant hematologist and hemato-oncologist, blood and heart clinic, Kingsway Hospital, Wockhardt Hospital, Nagpur. She's the director of Hemo Heart Foundation, ex-honorary assistant professor at Indira Gandhi Medical College, Nagpur. Her core areas of interest include sickle cell disease, ITP, lymphoma, and myeloma. She is also the principal investigator in multiple clinical trials. Today she is going to lecture us on transforming treatment paradigm in chronic lymphocytic leukemia. But before she does that, let me introduce our special guest and chief guest for the day, my friend Dr. Dharmesh Vagasia, who is hematologist, hemato-oncologist, and bone marrow transplant physician at Surat. Just to give his introduction to all of you, he did his MBBS from MP Shah Medical College, Jamnagar in 2008, followed by MD from BJ Medical College, Ahmedabad in 2013, and then DNB in clinical hematology from Sahyadri Hospital, Pune in 2017. He has the experience of working in Department of Hematology at Sahyadri Hospital, Pune for the period of 3 years. During this time, he has received extensive experience in doing all types of bone marrow transplantation. He has also experience of working for 8 years at Blood and Cancer Institute, formerly known as Surat Hematology Center at Athwagate. He pioneered the starting of BMT units in Surat and did the first BMT in South Gujarat. Till date, his team has done over 300 successful bone marrow transplants. It's my privilege to welcome Dr. Dharmesh Vagasia to inaugurate our webinar and give some words of wisdom. Well, I thank you so much. I'll stop over here. Over to you, Dr. Dharmesh Vagasia.
Thank you, Dr. Amit Khurana, for a nice introduction. And thank you, Dr. M.B. Agarwal, sir, for inviting as a chief guest. I am honored for gathering the newest generation of hematology. And hematology is not just about the cells, marrow, or molecule, it's about the life of itself. Every drop of the blood carries a story, and it's our privilege to read, interpret, and sometimes even write that story. You are entering a field at the time of remarkable change in the field of hematology, with breakthrough in genomics, targeted therapy, as well as immunotherapies that are transforming patients' outcome, but you navigate this new world with the scientific advancement. You have been trained to read CBC, analyze bone marrow biopsy, and interpret complex genetic sequencing. But these are just chapters in the large narratives, and the blood and bone marrow are not just tissue, they are the most intimate storyteller of the person's life. And the beauty of the hematology is that it constantly evolves the field. The same curiosity that made you pick up your first peripheral smear examinations will now fuel your breakthrough. And the therapy which once only the dream at the time of our hematology training, like gene editing, CAR T therapy, targeted molecular therapy, immunotherapy, that are now within our hands. And with the great innovations comes with the great responsibility. Now I will not be taking too much time for this wonderful topic, the innovating treatment paradigm change in the CLL. Now I hand it over to Dr. Khurana. Thank you.
Thank you, Dr. Dharmesh, for the wonderfully crafted speech. Thanks a lot. And thank you for accepting our invitation as the chief guest for the day. Thanks a lot. And
Thank
now,
you.
Dr. Ria, the screen is yours. Please go ahead.
Thank you so much, Dr. Amit. I would like to thank MHG and Professor Agarwal, sir, for giving me this opportunity. It's always a pleasure connecting with everyone on this platform. So the topic that has been given to me is changing treatment paradigm in CLL. And CLL, as we know, it prior to this lecture and CLL as we know it before this lecture, there's going to be a huge difference because last 1 year or so, a lot of advances have happened in CLL care. Hematology, three fields I would say have seen a lot of advances in the last couple of years. One is CLL, one is multiple myeloma, and the third is the area of CAR T therapy, cellular therapy. So let's move to the topic directly now.
Dr. Ria, can you make it full screen mode, please?
Yeah. Okay.
Yeah, perfect.
Yeah. So it's going to be discussed under the following subheads. First, we look at the evolution of CLL treatment till we know of CLL now. Then we look at the current treatment paradigm. What are we doing currently? Emerging trends, future directions, challenges and opportunities, and the road ahead. So what do we already know about CLL? We know that CLL is a disorder of the blood, which is characterized by the accumulation of monoclonal lymphocytes. And these lymphocytes are cancerous and they typically have this presentation. They are CD5 positive, 19 positive, 20 dim, and they have a light chain restriction. So this is the typical phenotype of CLL cells. We also, most of us know about this gentleman, Dr. Kanti Rai from India, who did his graduation, post-graduation in India, and pioneered CLL research as we know it today. In fact, so much that the staging system is based on this particular gentleman's name. It carries his name. So we have two staging systems for CLL. All these basics are for students who joined us today. We have the Binet staging, we have the modified Rai. So we can use either or of the two. I personally prefer to use the Rai staging because it goes into more details of the disease phenotype. So there is low risk, intermediate risk, and high risk. What is important for us is the high risk. And the high risk here is basically patients who have either developed anemia or they have developed a thrombocytopenia. If you can see what I'm highlighting here. So HB less than 11, platelets less than 10,000. This is the thing that we need to worry about. And this is the set of patients that needs treatment. We also have heard of this. There is a particular subtype of patients where this particular mutation subsite, where we have IGHV mutation status, and we know something called deletion 17p and TP53. So this particular phenotype, the patients who are IGVH unmutated, is bad. The patients who have deletion 17p, TP53, we know that TP53 is the worst mutation that any cancer can have. So any patient with a deletion 17p or TP53, which is positive, is the worst CLL that you can encounter. And any patient with the IGHV, IGHV refers to the immunoglobulin heavy chain region. So unmutated. Mutated is always good. Unmutated is the bad one. Just one moment. I use this marker and now I'm not able to close that. So just ignore this marker that is there, please. So for lymphomas, we know that we have something called the IPI prognostic system. Similarly, in 2016, IPI was devised for CLL. And which are the 5 points that are included? Most important for any tumor is the age. Then comes the stage. So we know that the stage 4 is the worst disease, 3 and 4. And Binet, if we are using it, is stage C. We know that deletion 17p is the worst prognostic factor. In fact, it carries 4 points. That is the highest in all these markers that we have. And we also know that the IGHV mutation status, the unmutated one, that also carries a poor prognosis. So in patients who are at low risk, so patients who have minimal risk factors, either 0 or 1, the 5-year overall survival is very good. Why is this important? This is important because in CLL, you do not treat all patients. It is only patients who have advanced stage. It is only patients who have a very high IPI. Those are the patients that would do worst, and those are the patients that you would treat. So to treat or not to treat, so we have these guidelines which have been laid down by the International Workshop Group for CLL, and we still use these guidelines, be it at diagnosis or be it at the relapse stage. This is the guideline that is used. So which patients of CLL are we going to treat? Are we going to treat all the patients? No. So this is a rough guide. So patients with advanced stage, be it stage 3, 4, patients with rapidly progressing lymph nodes. So you have a patient with bulky lymph nodes in the thorax, lymph nodes which are causing discomfort to the patient, which is causing obstructive symptoms to the patient. Those are the patients that you are going to treat. Cytopenias, because of disease progression. Now, cytopenias in CLL can be of 2 different categories. It may be autoimmune, which is common, seen in around, I would say, 15 to 20% of the patients. So in these patients, you treat them with minimal therapy first, mostly steroids. So if they don't respond to it, that is when you put the patient on chemotherapy. And the other cytopenia is when the disease is actually progressing. So that is when you actually need to treat the patient. B symptoms, weight loss, patient is having a recurrent or persistent fever, lot of fatigue, recurrent infections. This set of patients, again, you would treat. Lymphocyte doubling time is something that we use in our practice. So the lymphocyte, not the WBC count, mind you, it is the lymphocyte count, which has doubled within 6 months. That means that you need to start the patient on therapy. Now, when we were doing our post-graduation or even early in our DM, these are the drugs that we had heard of: chlorambucil, fludarabine, and bendamustine. So all these are chemotherapy drugs, many of them alkylators, some of them antimetabolites. And these are the drugs which, that's the only thing that we had. So either as monotherapy or as in combination with steroids or some other chemotherapy, that is what we did. Then came the era of rituximab. 1999, rituximab started being used. And since then, there is no looking back. So what did we start doing? We started combining our rituximab, our chemotherapy with the rituximab. And we got excellent results. We see the difference in the survival. And how does rituximab act? These cancer cells have CD20 molecule on their cell surface. It attracts the rituximab, it binds, and it causes a lot of downstream actions, which results in the rituximab acting. But now we know we are in 2025. So we cannot just talk of chemotherapy. We cannot just talk about monoclonal antibodies. We are in the era of targeted therapy, and that is exactly what we are going to be talking about. And I hope by the end of this talk, your take or your understanding on how you would treat your patient with CLL upfront would change. So like I said, it's a war between chemotherapy and our targeted therapy agents. So if you look at evolution of treatment, the first agent that was used in treatment of CLL was meclorethamine, which was an alkylator. We know alkylators have a lot of side effects, including second cancers. You see the evolution, 1999, approximately rituximab started being used. Then combinations, they decided why not combine the chemo with immunotherapy. And now all these latest drugs, we have the BTK inhibitors, we have the PI3K inhibitors, we have the BCL2 inhibitors. We're going to be talking about this because these are the drugs that are now approved for therapy of CLL. And the next generation, the future, we are going to be looking at that also. So if you look up this article, which was published in ASH, ASH is like the Bible for us hematologists. So our treatment, most of our guidelines, what we follow, the practical, the things that we do in our routine practice, ASH summarizes it very beautifully. And there is this series of how I treat, which again gives us a fair idea of how we should approach our patient. So 2010, if you type how I treat CLL upfront, this is what you would get. Symptomatic, of course, you treat. Asymptomatic, you don't treat. That stays the same. Even now, we still follow that. So what was the thing? Patient had a good performance status. Check the mutation, P53, like I said, that is the mutation to be checked. Patient has it. Put the patient on alemtuzumab. That is again a monoclonal antibody. Follow that up with transplant. Okay, so in a patient with P53 mutation, the only treatment was transplant, and the overall survival in these patients was a few months. Okay, no mutation, the treatment that was there was FCR chemotherapy, that is fludarabine, cyclophosphamide, and rituximab. And patient who was not fit, the only option was chlorambucil, nothing else. So this was way back in 2010. Come to 2019. 2019 is just 6 years back. So what was the treatment paradigm at that time? Again, the same thing. Look at the deletion 17p. And mind you, till today, patients with early stage CLL, we do not treat. There are a few trials which are trying it, but in our routine practice, we don't do it. So we treat only CLLs who are advanced or who have symptomatic disease. So again, the same thing, two bifurcations, deletion 17p present, ibrutinib only, nothing else. Ibrutinib. Ibrutinib is a Bruton tyrosine kinase inhibitor. We'll see what it is. So ibrutinib, you may add a monoclonal antibody. So you may add something like a rituximab or obinutuzumab. Deletion 17p absent, which is your good disease. Then you look at the other bad marker. You look at the IGHV mutation status. Mutated, go ahead with chemotherapy because it's a good disease. Unmutated, put the patient on ibrutinib or a clinical trial. So that is what we had till recently. Okay, now times have changed. So the pioneer article in CLL, which is first quoted and which was quoted when we were doing our studies, was this CLL-8 study and this one more study which was done by Fisher. So basically, they studied FC. FC is fludarabine cyclophosphamide combination in patients with CLL, and there was one more arm where they added rituximab. So basically, this study is basically looking into two things. One is the effect of adding rituximab. So you can see here, I'm not using that pointer again because it's just not disappearing. You can see here the first category, this first graph, if you can see what I'm highlighting. So it is patients who have received FCR chemotherapy and they are IGHV mutated. So like we discussed, IGHV mutation is the good mutation. you can see that the 5-year PFS is 67%. At that time, it was considered excellent. And you can see the patients with the worst prognosis is this dotted graph here, where they have just used FC, they have not used rituximab, and these patients are IGHV unmutated. So if you want to extrapolate, what does this tell us? It tells us that in patients who are IGHV unmutated, plain chemotherapy does not help, because you can see the PFS is hardly, it is, I would say, less than 20% there. Okay. And what about the sustained remission status? What about at 15 years, 20 years? So this data that we had, this was just at 5 years. So what about the long-term data? So in 2023, the long-term data was also published, where they found out that FCR is a good option in patients who are IGHV mutated, but not in the other patients. You can see the 3 graphs, they are really going down. The latest is almost come down to 0. So this is one category where you may, I'm using the word may, still use chemotherapy along with immunotherapy, because we have long-term data for the next 25 years also. Now, this was again the results of the CLL-8 trial, which is again an important trial as far as we go. And they analyzed it vis-a-vis the mutation. So previously we took the IGHV mutation status. Now they've taken the TP53 mutation. And what they found out was FCR did good in patients who had the wild type, which is the unmutated TP53, which is good. But in patients who had the TP53, which was bad, mutated TP53, the patients have done horrible. So what does this again tell us? Chemotherapy, immunotherapy does not act in patients with TP53 mutations and should not be used. If you are doing chemotherapy in these patients, the survival is a few months, or at most maybe 17 to 18 months. Okay. So long-term FCR, you would say 15, 20 years, 70% of your patients are alive, 40% are relapse-free. I'm talking about the IGHV mutated subclass. But at the cost of what? MDS, AML, and secondary malignancies. Because the fludarabine, which is there in this particular regimen, and even the cyclophosphamide to some extent, are known to cause secondary malignancies. So you have, and the chances are pretty high. They may be to the tune of 10-15% at the end of 10 years, 20 years. So you are giving the patient relapse-free survival, but at the cost of second malignancy. So what is the point of that survival? So that is why the need to find alternative therapies. The beautiful part about CLL is you can see this is a cluttered diagram, but you can see there are so many pathways involved. And whenever in any malignancy, so many pathways are involved. The good part is you can actually use this to develop newer and newer drugs. And that is exactly what has happened in CLL in the last few years. So first they came up with this enzyme inhibitor, BTK. BTK stands for Bruton tyrosine kinase. It's a very, very important enzyme when you look at the BCR receptor downsignaling. And these are the molecules that targeted. Ibrutinib was the first generation. Then came acalabrutinib. Now we have zanubrutinib, and you have the 4th generation molecules also. Next came the molecule PI3 kinase inhibitors, that is phosphatidyl inositol 3 kinase. Good molecules, but because there was a lot of safety concerns, like idelalisib was something, there was a big craze of it way back. But what they found out in the post-marketing studies was that a lot of patients developed colitis, so much so that they had perforations and a lot of patients died. That is why they withdrew the molecule from the market. And you have some more molecules here, which we would be discussing about. Most important here is this particular molecule, BCL2. As we know, it is an oncogene, proto-oncogene, which inhibits apoptosis. And we all know the molecule that targets it is venetoclax. So these are the newer kids on the block, and these are the molecules that we would be discussing. The same thing here. the different molecules and their sites of action. And as far as anti-CD20 is concerned, we have a second generation CD20, which is called obinutuzumab. We also know it as Gazyva. And this is the molecule that is again being used in most of the CLL protocols upfront. So the good news for us and our patients of CLL is that the days of chemotherapy are almost over. And I'll show you why I'm saying that. Why am I saying that FCR and BR is now obsolete? So it is basically a war between the two titans, between the titans BTK inhibitors and BCL2 inhibitors. So between your inhibs and between your venetoclax. So which are the BTK inhibitors that we have? We have ibrutinib, which was used, had side effects, we use it less. We have acalabrutinib. We have generic versions of this molecule. We are using it a lot. We have zanubrutinib, just launched in our country 2-3 months back, available for us. And we have pirtobrutinib, FDA approved in 2024, but not yet available in India. So these are excellent therapeutic options. Coming to the first molecule, ibrutinib. So the first trial that was done of this particular molecule was the Resonate-2 trial. So what they did was the standard of care. This was way back, I think, in 2000 something that they did it. It was published in 2015. So I think they started recruitment way before that, in 2008 or 9, if I'm not mistaken. So they used ibrutinib, and the standard of care at that time was chlorambucil. So as we know now, chlorambucil, we very rarely use it now. So they compared single agent ibrutinib along with chlorambucil, which is now, of course, not the standard of care, but that time it was. And what they found was ibrutinib, you can see the PFS difference. At 20 months, PFS was not yet reached in the ibrutinib arm. And you can see the difference in the OS and the PFS by the graphs. You can see that ibrutinib really scores over chlorambucil. So then the standard of care changed. We had rituximab or all these agents which were being used, which were approved. So what they did was, this was the second trial where they compared ibrutinib with rituximab versus FCR. So they've taken FCR in one arm and they put ibrutinib. And the thing about these Bruton kinase inhibitors is you need to give it long term. So the patients received ibrutinib and rituximab for 7 cycles. The rituximab was stopped, and then they put the patients on ibrutinib maintenance till progression. So that is something that is not so good, but good in the fact that you can see the PFS difference, you can see the OS difference is marked. So if you look at the IR arm with the FCR arm, IR arm has done so much better. And the best part, like I said, in patients, a few subset of patients, you may still use, though not recommended now, you may still use chemotherapy, be it FCR or BR. But in patients who are IGHV unmutated, look at the graphs, if you can appreciate here. IGHV unmutated, the graphs are so much separating. So in this, chemotherapy doesn't really help. And mutated, if you look at what it is highlighted here, it's going parallel. Your IR is still scoring about your FCR, but the difference is not so much. Now came the next study where they studied ibrutinib versus, they had 3 arms here. The first arm was ibrutinib monotherapy. So what they said here is, why not let's try ibrutinib versus ibrutinib rituximab. Is rituximab adding to the benefit at all? Or single agent ibrutinib, is it good enough? So there are 3 arms here. First was ibrutinib. Second was ibrutinib with rituximab, and third was your B plus R arm. So what did they find out? They found out that when you looked at ibrutinib versus ibrutinib with rituximab, the results were almost the same. You can see here, especially the curves are all going together parallelly. So what they found out was that addition of rituximab did not really help. So ibrutinib mono was as good as ibrutinib with rituximab. This is important for us. And when you look at deletion 17p again, you can see the graph here down. Chemotherapy is doing very poorly. Patients with deletion 17p, take home message, no chemotherapy. Now the next trial. Now the trial was with rituximab was done. So they thought rituximab is not giving any additional benefit. Why not use the second generation mAb? So the mAb that they used was obinutuzumab. So you have ibrutinib with obinutuzumab. You have chlorambucil with obinutuzumab as the comparator arm. And this was the pioneer Illuminate study. Illuminate study has, it's basically sort of laid down the foundation for all these newer therapies and finite therapies. So what they did was limited therapy, time limited therapy in patients with ibrutinib obinutuzumab versus chlorambucil obinutuzumab. And in some patients, they decided to continue the ibrutinib, and you can see the difference. So ibrutinib with obinutuzumab, the patients are doing excellent. Even the high-risk patients, this graph here is showing you your TP53 mutated patients, they are doing excellent. So you can say that ibrutinib is sort of partly at least offsetting the effect of your TP53 mutation. The first trial that we saw, the Resonate trial, where they compared Imbruvica with chlorambucil, 10 years, the 10-year data was presented at the EHA conclave of 2024. And what did they find out? That patients who had ibrutinib, some of them were still surviving, many of them were surviving rather, and around 60% of them were progression free, which is excellent at the end of 10 years. And chlorambucil, almost none of the patients were surviving. All of them had developed progressive disease. So that is the beauty of these newer drugs. And it was just one drug which was used, ibrutinib monotherapy. The same thing, the graphs, different mutations also they studied. Deletion 11, also we know that it confers a somewhat poor prognosis. But with ibrutinib, that effect was also mostly offset. So ibrutinib is a wonderful drug, you would say. It's giving such excellent results. Then why are we not using ibrutinib much? Why have we switched to the newer generation drug, acalabrutinib? Why? Because ibrutinib had a lot of side effects, and we see it in our routine practice. It causes atrial fibrillation. The worst thing that can happen is arrhythmias in the patients. So in fact, in the trials and post-trial settings, and even in clinical practice, some patients have been brought dead because of arrhythmias. So very severe arrhythmias, bleeding, accelerated hypertension, and infection. Some amount of arthralgia and flu-like syndrome. But the things that are to be worried about is arrhythmias, bleeding, uncontrolled infection. And that was pretty high. Around 30 to 40% of the patients had severe manifestations of these side effects. So what next? And why does this happen? It happens because ibrutinib is not a selective BTK. So it just doesn't go to the BTK and bind it. It has a lot of other off-site effects. So it interacts with a lot of other kinases. And that is why the side effects. If it affects the PI kinase, it causes cardiac side effects. If it affects the kinases, thymidine kinases in the T cells, it affects your immunity. So because of these off-site effects, ibrutinib was sort of, I won't say it is put off the shelf, it is still available, but we don't use it much. Now look at acalabrutinib. It is just acting on what it needs to act on. The off-target side effects are minimal. Okay, the same thing again. The blue, what is highlighted is your BTK, and the others are your other off-target effects. So this is another drug. We'll be discussing about this. The latest entrant to the BTK armamentarium, and that is zanubrutinib. Again, the off-target effects are much lesser than ibrutinib. And again, it is a much, much more powerful and better drug. Why this is important, we will see. So coming to the next BTK, acalabrutinib. So this was again a pivotal trial. It is called the Elevate TN trial. So all these, whatever we are discussing, mostly it is in the upfront setting, because relapsed CLL is a different topic altogether. So acalabrutinib, they had 3 arms. One arm, just acalabrutinib. The second arm, acalabrutinib with obinutuzumab. And the third arm, chlorambucil with obinutuzumab. So of these, chlorambucil, obinutuzumab, that was finite therapy. 6 cycles, you are done. No more chemotherapy. About acalabrutinib, mono or in combination with obinutuzumab, you had to give the acalabrutinib throughout till progressive disease. So continuously give it. And the endpoint that was analyzed was the progression-free survival. What did they find out? Interesting again. Chlorambucil, even after addition of obinutuzumab to it, the results were not significantly improved. They were okay. They were better than what it was with only chlorambucil, but not as much as expected. The PFS was just 17%. If you compare it with patients with acalabrutinib and obinutuzumab, I want you to look here. Acalabrutinib and obinutuzumab, the median PFS has not been reached, and overall 78% of patients have not progressed even at 72 months, which is great. And again, you can see addition of obinutuzumab to single agent acalabrutinib has given us better results. So addition of rituximab to the BTKs, not much benefit. Addition of obinutuzumab to the BTKs, very significant benefit. So did this stay across deletion 17p and IGVH mutation? Yes, the benefit stayed across them. Okay, so now you know in CML there is a concept of treatment-free remission. Treatment-free remission means you treat the patient for a period of time, get the patient into molecular remission, and then stop the treatment. So is such a thing possible in CLL? Can you use these medicines in a finite way, stop it, and expect your patient to do good for the next few years? There comes the role of zanubrutinib. That is the third generation BTK inhibitor. Beautiful drug. The first trial that was done, obviously, when you have new drugs, it is mostly tested in the relapsed refractory settings. So the Alpine trial is which zanubrutinib was studied in the relapsed refractory settings. Then came the Sequoia trial, and they studied zanubrutinib in the upfront setting. So basically, there were 2 arms. One was zanubrutinib monotherapy. The dose of zanubrutinib is 160 mg twice per day. And in this, they continued. We're going to be talking about the time-limited therapies later. This is basically continuous therapy. This sets the tone for the time-limited therapy, what we'll discuss later. So zanubrutinib, they have given continuously 1 arm, and the other arm, they have used B plus R. Okay. And important, they have 2 more cohorts. In the second cohort, they have used zanubrutinib only in patients with deletion 17p. So the first set was patients without deletion 17p. Second set is deletion 17p. We know that B plus R will not help at all. Then why put the patients at all on that molecule? So those patients were put on zanubrutinib. And cohort 3 is very interesting. They've used zanubrutinib and venetoclax combination in patients with deletion 17p. So very interesting trial. So what did they find out? They found out that in patients who were on zanubrutinib monotherapy, the PFS was 82% at around 46 months versus B plus R, it was 50%. So this is one set of patients without your TP53 mutation. The second cohort was your patients with TP53 mutation. Just look at this. It is so beautiful. So patients with TP53 mutation, we have been told they do bad. It's the worst disease. They don't survive beyond a few months. But look at this. In patients with deletion 17p, the PFS is almost the same as in patients without deletion 17p. So here it is 79% and here it is 82%. So this is one drug that can be your go-to drug in patients with deletion 17p mutation. What about the side effects? You would say it's a powerful drug. So obviously the side effects would be much more. The answer is no. The only side effect of where zanubrutinib, the side effect is slightly more than ibrutinib, is neutropenia, because it's a very powerful, potent drug. All other side effects, be it cardiac, be it bleeding, are much lesser with zanubrutinib than ibrutinib. And the thing, like we discussed, some patients can come with life-threatening arrhythmias. Incidence of cardiac side effects with zanubrutinib is almost zero. Everything else is manageable. So beautiful drug. So now, there are some patients who have been on ibrutinib or calibrutinib. They don't tolerate it for whatever reasons, cardiac reasons, accelerated hypertension, infection. You have stopped the drug. You have no other option. And what can be your go-to drug? It can be zanubrutinib. So this was a trial where they studied the safety and efficacy results of zanubrutinib in patients who were intolerant to, not resistant to, intolerant to ibrutinib and acalabrutinib. This was the study design. Very simple. Intolerant, put on zanubrutinib, monitor for side effects and tolerance. So what did they see? They saw that in 84% of the patients, the side effect did not recur. So the side effect for which you had stopped your ibrutinib did not recur in 84% of the patients. Now that's a big number. And rest of the patients also, it may have recurred, but mostly it was mild. Only in 10% it was at the same grade. Okay, so that is what we've seen here. So this is my statement. Ibrutinib is still used in treatment of CLL. I have one patient on ibrutinib. Everyone else, we put them on the other BTK inhibitors. This is my personal statement. I'm not quoting anyone here, that the first generation BTK inhibitor ibrutinib is now obsolete in CLL care because of the side effects. So if you're getting side effects, you are going to stop treatment. If you stop treatment, your patient is going to get a refractory disease. So the best that we have now are acalabrutinib and zanubrutinib. Good safety and excellent efficacy. So this was your ibrutinib, now getting obsolete. This is your acalabrutinib and maybe your zanubrutinib. And this is the BTK of the future. What is it? So the future BTK inhibitors are something called non-covalent inhibitors. There we have these two molecules, pirtobrutinib and nemtabrutinib. Of this, pirtobrutinib has been FDA approved, not yet available in India, but we hope it would be in the near future. And the next set of drugs, which is beyond BTK inhibitors, is something called BTK degraders. BTK degraders means this molecule just does not inhibit the enzyme, but it degrades it. So you can understand what a powerful impact it can have in CLL treatment, degrading the causative enzyme, the culprit enzyme completely. So these are the two molecules, NX2127 and 5948, that are in study, not yet approved. So this is pirtobrutinib, which is available outside. Maybe we are going to be having it. When it comes, zanubrutinib we have, obviously it's a good drug, but we may also look forward to this particular molecule. Now, the problem that we saw with all these BTK therapies is that they recommend continuous therapy, all the trials, and that is what we are practicing. Continuous therapy till progression. So patient has to take the tablet almost lifelong. So any solution to that? Because now we are in the era of time-limited therapy, personalized medicine. There comes venetoclax. Venetoclax says, I have arrived on the scene. BCL2 inhibitor, excellent. We know we are using it in our AMLs with excellent results. Even in CLL, venetoclax has excellent success rates. Various combinations with venetoclax are showing fascinating results in CLL. Okay, so regarding this, the first study was the CLL 14 study. venetoclax with obinutuzumab. I think this is something that Dr. Khurana was just discussing some time back. So we have venetoclax and obinutuzumab, one arm, and the other arm is chlorambucil with obinutuzumab. So the other studies were what? You used ibrutinib with obinutuzumab. Now it is venetoclax with ibrutinib, with obinutuzumab. Okay? And time-limited therapy. If you can see it, 12 cycles only and done. Okay? So 12 cycles, stop, and then monitor the patient. So if you can see here, venetoclax, obinutuzumab, PFS very much above your chlorambucil obinutuzumab, and there is some difference in the OS also. Now, honestly, we know that venetoclax has one flaw, because of which it is not a very good drug for TP53 mutation status. So it does do good, better than your chemotherapy, but it would not be the go-to drug in TP53 mutated status. So the good part of all these treatments was that it is a time-limited therapy. What about the side effects? Almost comparable to chlorambucil obinutuzumab. Tumor lysis syndrome is a truth with venetoclax, but to offset it, venetoclax is started later. It is normally started from cycle 3 onwards. By that time, the risk of tumor lysis is minimal. Cytopenias are again slightly on the higher side, but manageable. So no life-threatening side effects as such. So pretty safe drug. So now let's look at another concept in CLL, and that is MRD. We've heard of MRD in ALL, AML, then multiple myeloma, and now we are talking about MRD in CLL. So the trial that explored this was again the CLL-13 trial. So using venetoclax, adding venetoclax to your backbone of your BTKs or your monoclonals is helping you get a MRD negative status. So CLL3 study design, 13 study design, venetoclax, rituximab, venetoclax, obinutuzumab. And again, you can see this is something new. This is triplet combination. So if you decide, if you say that 2 drugs are good, why not try combining all 3? Why not use venetoclax and ibrutinib and obinutuzumab, all 3 drugs together? So they've used all 3 drugs together, mostly time limited, but here in this last arm, they've used something called MRD to guide therapy. So if the patient has not achieved MRD at 15 months, ibrutinib monotherapy has been continued to up to 36 months. So this is something which is new. So 2 things we have seen here. One is MRD monitoring to assess prognosis, and second is MRD guiding to assess duration of treatment. So you can see in patients where the percentage of the patients who have achieved undetectable MRD is the highest in this arm. All 3 combined, Gazyva, ibrutinib, and venetoclax, if you've used together, the incidence of undetectable MRD, which is defined as a MRD less than 10 raised to minus 4, is 92%, which is way, way, way high than your chemoimmunotherapy. And this benefit stays across all arms. Even your patients with TP53 mutation, IGHV unmutated, all these do excellent with this. All of them achieve MRD negative. So much so that in one of the papers that I read, what they said that MRD has now replaced your IGHV and TP53 mutation as the sole important marker for CLL. This is a very, very important statement. So what they mean is the patients who have achieved MRD negative, even if they were IGHV mutated, TP53 positive, these patients would do excellent irrespective of this status. So looking at the drugs again, look at chemoimmunotherapy. Good part, 6 months treatment, your patient is happy. Just 6 months, patient happy, goes back home. But the bad part, the infections, managing the cytopenias, it's IV therapy, and the secondary malignancies and the other effects which happen. Ibrutinib, looking at it, good part, patients are happy. Ibrutinib or any BTK, as a matter of fact, patients are happy because it is oral. But the problem is it needs to be taken indefinitely. Just keep on taking it, and the side effects. MRD negativity rate is lesser if you use it alone. Now look at the combination therapy. Venetoclax with obinutuzumab. Beautiful part, 12 months, finite therapy. Slightly bad part, there is a IV component also. But look at the outcomes. MRD negative survival, which is increased. So the bad part, the only bad part about this was it was IV. So can we look at a all oral therapy? So there comes this particular trial. BTK inhibitors along with venetoclax. You use both oral therapies. Different mechanisms of action, synergistic action, excellent results. So for the first time, ibrutinib and venetoclax was used, and our very own Dr. Nitin Jain was the PI for this study. This is one of the studies that have investigated ibrutinib with venetoclax for first-line therapy of CLL, and they had excellent results. You can see the PFS, it's almost 100%, 90%, 80%, beautiful. And even in patients with deletion 7, PFS is around 85-90%, which is excellent. This was again another trial. They had a comparator arm here. That was no comparator. This is comparator. Ibrutinib, venetoclax versus chlorambucil obinutuzumab. GLOW study, again a famous study. And you can see that the PFS with ibrutinib venetoclax is 66% at 54 months. At chlorambucil obinutuzumab, it is just 19%. One more study, Captivate study, similar thing. Again, similar result. Now coming to something different. The FLAIR trial, I like this trial because they have used MRD as a guide to stop therapy. So they've used two arms, FCR arm, and the other arm, it is venetoclax and ibrutinib. And what they have done is they have assessed the MRD at different time points, starting from 15 months up to 6 years. And if the patient has achieved a MRD negative, suppose the patient has taken 6 months to achieve MRD negative after your 15 months, give the patient treatment. You combine the ibrutinib and venetoclax both for another 6 months. Okay. And so double the time that is needed to achieve the MRD and stop there. So MRD guided therapy is what they have done, and they've got excellent results. And what is now hypothesized is, CR, we know the definition of complete remission in CLL. MRD negative CR is 10 raised to -4, no cells detected. Are we looking at a potential cure? Because there were some patients who had MRDs and results beyond this. So are we looking at a cure in CML with this MRD guided therapy? This is something that we need to explore. Now, again, what about zanubrutinib with venetoclax? Again, excellent results. Even in the highest risk population, you can see the overall response is 97%. The CR is 77. MRD negative is 80-90%. Beautiful results, minimal side effects. So I showed you how we treat CLL in 2010, 19, and now how do we treat CLL in 2025? TP53, of course, if positive, BTK inhibitor monotherapy, you may combine it with obinutuzumab. If it is negative, look at the mutation status. But all said and done, best treatment if IGVH-HV mutated, venetoclax with obinutuzumab, unmutated ibrutinib to be preferred with venetoclax or venetoclax obinutuzumab again. Unfit patients, all oral therapy or single BTK inhibitor. This is what we are looking at now. And the same thing has been adapted in the NCCN guidelines also. You can see first-line therapy, BTK inhibitor or CAL obinutuzumab combination, zanubrutinib, venetoclax, obinutuzumab combination. So this is what we have discussed already. What about relapse? Just a few slides on relapse. So relapse after first line fixed duration, ibrutinib and venetoclax. So your patients, so this was the Captivate study again. Patients had time-bound ibrutinib, venetoclax, stopped after 15 months. So what if these patients relapsed? Because you've given treatment only for 15 months. What after that? So they followed up these patients. And this was the percent of patients that relapsed. What they found was these are the mutations which cause resistance. Obviously, if you're using a BTK inhibitor, the resistance will be caused because of this enzyme. So these are the three main enzymes, BTK, BCL2, and PLCG2. So what they found was that patients did not acquire mutations. Just one patient of the 40 that they studied acquired a mutation in one of these enzymes. The other patients did not. What does this mean? This means that you can challenge the patient with this particular medicine again. You can use the same thing again. Again, this is something that is really beautiful. And after using it again, they again see the response rate is excellent. Adverse effect profile was also similar. So in patients with relapse, this is what we follow. I don't think we have time to discuss this, but if a patient has received BTK before, try to avoid it, because you try to more focus on a venetoclax-based therapy. If patient has received venetoclax, you try to focus more on a BTK. If patient had not received both, you can use both. And the newer drugs that are there are your non-covalent BTKs, your pertuzumab and nemtabrutinib, clinical trials, and CAR-T. CAR-T therapy and cellular therapy is coming up in a big way for CLL. What about triplet therapy? We saw it, combination of all three. Excellent response, 92% undetectable MRD, nothing like this. So this is the thing of the future. BCR inhibitors, your aim was disease control. With BCL2 inhibitors, your aim is disease eradication with finite treatment. Emerging trends, the newer things which are coming are CAR-T, CAR-NK, and we are looking at triple therapy combinations. We are looking at a MRD guided approach. That was it from my side. To conclude, I would say targeted therapy has revolutionized the treatment of CLL. Fixed dose therapy to be preferred over continuous BTK inhibition, and excellent results. That was it from my side. Thank you very much.
Thank you, Dr. Ria. Wonderful lecture. Fantastic. You covered almost everything of chronic lymphocytic leukemia up to date till 2025, 12th October. Fantastic. And now I request all our discussants to please put the hand raise sign so that you can start a question session with Dr. Ria Baliga. Yes, Dr. Rama, please go ahead.
Good morning, everyone. Ma'am, I have one question. In CLL, IGHV mutated and unmutated status, what is the treatment? Is there any difference, or what is the treatment you are going to give if it is mutated?
Dr. Ria, you muted.
There was some network problem. Can you get the question again, please?
Yes, for mutated CLL as well as unmutated CLL, what would be the treatment option now? The frontline treatment option for
Frontline treatment option.
Unmutated both.
Unmutated and mutated.
Yeah.
So if I have a patient with unmutated CLL, we know they do good. So if money is not a problem, then I would prefer venetoclax with obinutuzumab, finite therapy. That would be my go-to. But if money is a problem, we know that in patients with unmutated, even chemotherapy can help. So FCR and B plus R can also be tried, because as we know, venetoclax and obinutuzumab are slightly expensive. But if you're looking at a unmutated CLL, then your chemotherapy is not going to really help. You would do ibrutinib, not ibrutinib, I would say acalabrutinib in combination with obinutuzumab or venetoclax. Or if your patient is not affording, not very fit, then you would go for a BTK monotherapy, preferably acalabrutinib or zanubrutinib.
Perfect.
Okay, ma'am. Thank you.
So this is for the upfront setting. For relapse setting, if the patient has already received ACL plus VEN, what would be your treatment of choice? Relapse or ACL and both.
So your patient has received both a BCL2 and your patient has received a BTK inhibitor also. So now two things here. Was it finite therapy or was it a continuous therapy? So if you're looking at a finite therapy, like I said, after 2 years, so if your patient had achieved a response for 2 years post stopping this therapy, you can give the same combination again. There is data to support it. But if your patient has relapsed while on a calibrutinib and venetoclax, suppose your venetoclax was just for a finite period of 12 months, you had continued your acalabrutinib, then you cannot use your BTK inhibitors again. So in this case, the best treatment option would be enroll in the clinical trial. Not available to you, the second best option would be maybe use the venetoclax again with obinutuzumab. Third option, not available again to us here, but pirtobrutinib, which is the non-covalent BTK inhibitors, the newer ones, and relapsed even after this, then CAR-T would be the next go-to option.
Perfect. So for upfront CLL, elderly patient who already has ejection fraction of 45, say for example, 45%, and already patient is on some antibiotic therapy, elderly is about say 75 years of age, CLL, the indication of treatment is basically low hemoglobin and a low platelet count. So what would you have upfront therapy of choice? Patient is known TP53, known IgHV mutated.
So honestly, in this patient, I would prefer to use zanubrutinib. This patient, my go-to drug would be zanubrutinib, because with zanubrutinib, with the Sequoia trial and the Alpine, they have used it in elderly, frail patients with cardiac issues also, and they've not found much of side effects. So venetoclax, normally the elderly may not tolerate that well. So if money is not a problem, I would go for zanubrutinib in this patient.
Ma'am, this works with TP53 mutation as well, ma'am?
Yes. Zanubrutinib, your BTKs, irrespective of the TP53 mutation, they do good. This is one take-home message here. TP53 never aim for chemotherapy. Never. Chemotherapy, the patients don't do very good. Venetoclax, there is data that if you combine venetoclax with obinutuzumab or a BTK inhibitor, the patient would do good. But venetoclax monotherapy, again, in such settings is not recommended, because intrinsically the TP53 clone, it causes resistance to venetoclax. Because of some mechanism, the BCL2 antagonist cannot really act. So the best drug here would be a BTK inhibitor, especially zanubrutinib.
Okay, ma'am. Thank you.
Yeah.
So any other question, anybody else? Okay, one question I have, if the patient has to be taken for surgery on BTK inhibitor, how can you go for it?
Very
When
nice question. Very nice question. In fact, recently we had a lady, she was on acalabrutinib and she fell down. She was, I think, 85-year-old. She had a fracture femur, CLL on acalabrutinib. So we got a call. She was almost to be taken for the OT. What is important to remember here is BTKs, they cause a platelet function defect. So the chances intra-op of having a massive bleeding is huge. So if you have an elective surgery, you should stop the BTK for at least 7 days and then take the patient up. But if you are in an emergency surgery, you have to give platelet transfusion to these patients. Otherwise, the patient is going to bleed on table.
If the patient is already on anticoagulation, then?
Anticoagulation, normally we avoid using ibrutinib because interactions are a lot of interactions. It is not recommended. In fact, anticoagulation ibrutinib is contraindicated, but zanubrutinib is the only one which is indicated with anticoagulation. There is no interaction, no increased risk of bleeding. So zanubrutinib can be safely given with your anticoagulation. And if the patient is on anticoagulation and planned for a surgery, you mean?
Yeah, patient is already on anticoagulation and now planned for surgery, because now this is a big problem.
Yeah, so ibrutinib and alkyl, normally your patient would really not be on anticoagulation. Patient would be on some other treatment. But with zanubrutinib, anticoagulation would depend on what Elective, you stop the anticoagulation again. Emergency surgery depends on a lot of things. What was your anticoagulation for? Was it cardiac? What? How long can you stop it? So if you can stop it, stop it. Go ahead with the surgery. Cannot stop it, you give plasma, you give SDP, and then do it. If it was a NOAC, then sometimes you even have to give your PCC, prothrombin concentrates, also along with the platelets.
There is one question related to how do you make a decision for the upfront treatment named CLL? Which patient must be offered Ven Obino, or which patient must be offered upfront BTK inhibitors? So, in your practice, if the patient is treatment naive, say for example, healthy, fit patient, young patient, which patient would you go for Ven Obino, and which patient you will go for BTK inhibitor? Any specific categories you will have?
Very nice question. So it would depend on a lot of things. Now, it would depend on the fitness level of your patient. This patient is young and fit. It would depend on the comorbidities. So if the patient has any cardiac issues, I would not use ibrutinib or acalabrutinib. If the patient has a chronic kidney disease, patient is dialysis dependent, I would not use venetoclax. That is one thing. Second thing is your patient preference. Does your patient want injectable therapy, which is time limited? Does your patient not want injections? There are some patients who say, I don't want to take injections. I'm okay taking tablets all my life. So in such patients, you give them your BTK inhibitors lifelong. Because if you're using BTK monotherapy, you can't stop the treatment. You have to continue it. So if your patient is young, fit, no renal compromise, okay with taking injectables, affording, that's a big thing in our country, I would prefer venetoclax with obinutuzumab. But if your patient is not that, then it's a BTK inhibitor.
Thank you. Another question is in those patients which I already discussed with you regarding the dual refractory patients. For example, patient already has been put on BTK inhibitor, BCL2, both are exposed together. You said very clearly after 2 years you can restart the same regimen again. But suppose if the patient relapses, say for example within 6 to 8 months, and you have got 3 options now. One, clinical trial whatsoever. Second, you said about CAR T cell therapy. And third, you also have the bispecific antibodies. So out of these 3, what would be your flow chart? This is the first, second, third.
First would obviously be a clinical study if anything is available. Like we do a lot of clinical trials in our center. We have something for myeloma, AML right now, nothing for CLL. I don't think there's anything for CLL right now. But if there is, then the first thing would be CLL, would be a clinical trial. Not that, then if you can, get hold of pirtobrutinib, maybe that can be tried. Maybe that can be tried as monotherapy also, because I was going through the data. Pirtobrutinib in relapsed refractory patients has been found to do good, excellent actually. So that is something that can be tried. And like you said, CAR-T is something which is there. CD19 CAR-T is something again. And there is some data of CAR-T combination along with the BTK inhibitors also in refractory patients. So there is that data also which is coming up. And if you have nothing and your patient is really doing bad, then in our country, we always have the option of allotransplant. Glofitamab is again something that can be used, but not much data on that. So maybe a transplant if nothing else works.
Thank you. And another question is, suppose your patient relapses on AKELA. Patient relapses on AKELA. And now you've got 2 options to choose. Perto versus your BCL2 inhibitor. What would be your advice for the patient? AKELA relapsed, to go for Perto or to go for venetoclax-based regimen?
I would prefer venetoclax with obinutuzumab in this patient. That would be my go-to thing because of availability also.
Okay. If it is easily available, for example, both are easily available, Perto and venetoclax. So would you go for Perto or would you go for venetoclax?
Though the data says it would be a tricky situation. If my patient is unfit, I would go for pirtobrutinib because it has good data in failed patients also. But if it is a fit patient and I have venetoclax and obinutuzumab, I wouldn't really want to re-challenge with a similar class of drugs because venetoclax, obinutuzumab, the patient is naive to these drugs, so you can consider using it.
There is some question related to MRD, because now everything is being shifting towards the MRD based strategy.
Yeah.
So, do you still believe that MRD negativity should become a mandatory endpoint in clinical practice, or should it remain as just a research tool only?
Yeah, so good question again. So in CLL, MRD is still in the clinical trial setting only. We don't do it in our clinical practice. But if we are to use time-bound therapies, finite therapies, if we are going to be saying that I'm going to be treating my patient for 12 months, 15 months, and then stopping it, I think in the next 1 or 2 years, MRD in CLL would be something that would be integrated into clinical practice. If we are looking at finite therapy. But if you want a patient, if you're giving chemotherapy, if you're going to give your patient indefinite BTK inhibitors, then MRD wouldn't really have a role.
Well, I've got one more question related to a case basically. A 49 years old male who presents to you with a hemoglobin of say 4.5 grams, a MCV of 105, peripheral smear shows there are spherocytes, and direct Coombs test is 3 plus positive. So you make a decision to start the patient on acalabrutinib. Is there still a role of giving steroids to such patient? Because patient is already having a direct Coombs test positive AIHA with CLL, and now you already taken a decision to start the patient has been started on Akela. Whether it is necessary to add steroids with Akela, or just Akela is enough, because that will take care of autoimmune manifestation of CLL also.
Yeah, again, a very nice question and slightly tricky to handle, because autoimmune manifestations are seen in CLL. And if we have plain autoimmune manifestations, we try to defer starting the chemotherapy. We normally give the patient steroids or a single agent rituximab. But in this case, there is AIHA, there is thrombocytopenia. You don't know if the thrombocytopenia is autoimmune or it is infiltration. So what I would do is I would do a bone marrow in this patient. I would see the infiltration. How much is the infiltration? If it's a diffuse infiltration, I know that the disease is also contributing to the cytopenias. Then I would add, if the patient is unfit, a cal, yes. But otherwise, maybe in this patient, a rituximab based therapy, something like a rituximab steroids is what I would use upfront, and then put the patient on Acala. But if it is because of disease itself, then Acala and plain Acala may not help. I would add steroids here, or maybe even rituximab for the autoimmune part, not for the CLL.
So in place of Obino, what the Elevent TN studies showed about Akela plus Obino,
Yes.
just opposite of that, if you can go for Akela plus rituximab in this setting, will you find?
No, there is data of ibrutinib with rituximab, but Acala and rituximab, I could not get any data. But OFA, again, with autoimmune, we have not been using it. We don't have much data. So this particular subset, like I said, rituximab, I'm not giving for the CLL. I'm giving it for the autoimmune part. Your Acala can alone take care of the CLL. But there is no data of Acal with obinutuzumab, to the best of my knowledge.
Thank you. Another question is related to the atrial fibrillation on the patients of acalabrutinib. A young elderly patient, 65 years, develops AF on Acela, not suitable for Zenu because he has got financial constraints. So what would you do next? Would you switch over to Acela or remain on Acela with a dose reduction, or what so?
Again, a tricky question. Acala doesn't cause too much of fibrillations. Your ibrutinib did cause a lot of it. But if the patient has it, it is not advisable to continue this, because sometimes the AF can convert into a ventricular arrhythmia also. And the patient can have a sudden cardiac death and other problems. So if the patient already has a AFib, I would not continue the patient on Acal, because one option that was suggested is dose reduction, but these side effects of BTKs, they are not dose dependent. It's more of idiosyncratic. It is more because of those other enzymes which are involved. So dose reduction, I don't think would settle the problem. We would have to switch therapy, give something else, offer something else.
Thank you. Dr. Rama, your question?
Ma'am, I have one more question. CD38 high CLL, is there any role of bispecifics, and is there any approved bispecific treatment in this case?
See, the CD38 was something, it's a surrogate marker for ZAP70 and IgHV unmutated status. So CD38 high bulk CLL, there was some data initially that it had some prognostic significance. But now with all your BTK inhibitors, they have nullified the effect of CD38 or a high bulk disease. They do excellently well. But in patients with a high bulk disease, CD38 positive, adding venetoclax to the arm would help. Now, regarding your bispecifics, upfront, there is no recommendation of using any bispecifics, but in the relapsed refractory setting, you may try.
Okay, ma'am. Thank you.
Yeah.
There is a last question related to sequencing of therapies.
Okay.
Patient relapsed on BTK. What next? Relapsed on BCL2. What next? And relapsed on BTK plus BCL2. What next? So the
Yeah.
sequence.
So there was when I completed one of the last slides was this: relapsed on BTK, used BCL2 in combination with obinutuzumab. Relapsed on BCL2, used BTK inhibitor in combination with obinutuzumab or a monotherapy. Relapsed on both, the patient should be put on trials or pirtobrutinib, CAR-T.
Perfect. In place of, because Obino is a very tough to give to the patients, because in Indian setting, giving Obino is again a big question mark. And so can we use rituximab in place of Obino? Because Obino, one is expensive, first thing, and second thing is basically it's a very toxic thing to give Obino. So many patients of Indian patients may not tolerate Obino.
Yeah.
Can we
So
replace
in
Obino with rituximab?
elderly, honestly, it is not really recommended to give it. In fact, I had a patient with a relapsed follicular lymphoma. We used obinutuzumab in him, and he had severe cytopenias, severe cytopenias. So I agree, it's a difficult to handle drug, but it has excellent results. So if a patient is young, fit, and affording, now with patient support, the cost of obinutuzumab has come down. Per cycle, it's around 1 lakh, which many times, if you need to take the total doses that you need to take are 6 plus 2, that is 8. That's 8 lakhs. So if patient can take that much, I still recommend it in young fit patients, because what we saw that adding rituximab to your BTK did not really help. But in elderly patients, if you want to give a combination therapy, yes, you may still use rituximab, considering the cost and the safety profile.
Thank you. And the last question is again a case scenario. He is actually a 60 years old male who has been started on ecallantide because of the low hemoglobin. It's a case of chronic kidney disease. Patient was on dialysis, maintenance dialysis, and the hemoglobin was maintaining around 6-7 on dialysis with erythropoietin running at 10,000 units twice a week. And uh, the nephrologist said that this low hemoglobin is nothing to do with CKD. So it was decided that the WBC count was 35,000, and the patient was put on ecallantide, and then the WBC count just rose from 35,000 to became 1 lakh, around 95,000, 1 lakh. So we know that ecallantide can cause steep rise in the WBC count as well as even the lymph node enlargement. At what point of time would you really investigate thoroughly that whether this is because of Ecala or is because of the Richter's transformation? And if it is so, what mutation study would you like to do and what you would like to do next?
Okay. So Richter's transformation, one important marker is your LDH. So upfront, I would do the LDH. If the LDH is high, maybe it would point towards it. But like we know, Acala can cause lymphocytosis transient. It peaks around 1 day. It starts from day 1, peaks by the first or second week, and it can last up to 2 months. So I would, if it's not really rapidly increasing, the patient is okay, I would wait for a period of 2 months if your LDH is normal. But the same patient again, B symptoms developing, LDH increasing, then I would prefer to do a PET-CT and a bone marrow to see what exactly is happening in this patient.
Any cutoff for the WBC count?
For?
To rise in the WBC, the lymphocytosis, what is happening?
No, I don't think there is anything. We've seen patients who've gone up from 80,000, 1 lakh to even 2.5 and 3 lakhs. You just need to hydrate the patient post Ocala, and it settles within a couple of weeks. It may persist till 2 months, but it usually settles. So I don't think there's any cutoff. But in CKD patients, you need to be monitoring for a spontaneous TLS-like picture that happens. So uric acid, LDH, and all those parameters should be checked. No cutoff as such.
So before taking a decision for making from covalent to non-covalent inhibitors like pirtobrutinib, do we need to check for C481S mutation every time, or is it not indicated? Because you are changing from covalent to non-covalent. Is mutation study matters and by any means? Because mutation study, if it is positive, then okay. If it is negative, then still would it go for a non-covalent one?
Mutation studies, the ones that we
The
have available.
most important was that C481S mutation.
Yes.
So if it is positive, then PARTO is the only way out.
Yes.
If it is negative, still PARTO is the only way out. So every time are you able to check the mutation study before you take a decision for covalent to non-covalent?
So honestly, within covalents, if you ask me, and the mutations that we have in India, we just have the BTK mutation, we have the BCL2 mutation, and we have the PLC gamma 2 mutation. These are the only 3 mutations which are done in our country. Regarding this mutation, where you decide to switch from POTO to no, this is not available in our country. And in research settings, they have done it. The trial, I think, I forgot it. Bruin was the trial. Bruin was the trial where they've studied pirtobrutinib, and they have done the mutation before enrolling the patients. So if the patient is negative for that, then there is no point in using that drug. But I have no hands-on experience with this, so I'm not the right person to comment on it.
Thank you. And another question is from Dr. Tariq Ben Othman. Why BTK inhibitor are used as monotherapy, but venetoclax is always used in association with Obino or rituximab?
That's a very nice question, but I honestly don't have an answer to that question. But if I guess, then if I'm to guess, can you guess, Dr. Khurana, the answer?
No, that I think the whole is related to the mechanism of action only, because the BTK inhibitors is completely another different mechanism of action. Venetoclax
Yes.
is anti-apoptotic.
Yes.
It's apoptotic mechanism of action. So when you're using apoptosis, you're doing because you require strong apoptosis. So that's why you are combining Ven plus Obino for the synergistic action what Obino has. Because once you give Obino, the synergistic action of adding Obino with Venetoclax will markedly increase, and that's why the apoptosis is significant. And but in
And yeah, one more thing, if I may add.
Yeah.
BCL2 is basically it is a oncogene. It is a anti-apoptotic gene.
Anti-apoptotic, yes.
Yes. So and it acts when the cells are in the bloodstream. That's what I understand. So if the cells are in the lymph nodes, the liver and spleen, the cancer cells, the venetoclax will not be able to pull those cells out and act on it. So it needs something that will mobilize the cells. So your BTK would mobilize the cell, get it into the bloodstream, and then the venetoclax can act. So like Dr. Khurana said, it is more of a synergistic action. And venetoclax monotherapy, I don't think is approved anywhere. It is always in combination with.
And the reason is the same thing. Is the master the apoptosis pathway.
Yes, yes.
Well, so I think anybody has any other question? Well, so that brings to end of this webinar. So thank you so much, Dr. Ria. A wonderful lecture. You covered almost everything and wonderful question answer session with you. And I also thank our chief guest, Dr. Dharmesh Vakase, to join over here today. I also thank all our discussions today and all the audience participating today, and meet you next week, Saturday, Sunday, with another beautiful webinars. Thank you. Thanks a lot.
Thank you so much. Thank you for having me. Bye.
Thank you.
Bye.